you've already seen this slide now from Dr. Buerta, but this is just a bit of a reminder about obesity. And in our center, we're not just dealing with people who are a little bit overweight. A lot of them would have sleep apnea, on CPAP machines, obviously insulin-dependent diabetics, and we've seen patients with 200-300 units of insulin. A lot of patients on high doses of medication for high blood pressure, heart disease, and things like that. And just a little bit of something there about the quality of life. I had a patient just last week, and we were talking about the first time he saw me. And to get from the car park to my offices, which is about 300 meters, he had to stop 3 times just to get his breath. Now he's 3 years post-op, and he did the 94.7 in November. So it's a huge, huge change of life. So Dr. Buerta did briefly go through this with you. So not all patients will be fit for surgery. Patients need to be with a body mass index above 40, or they need to have a body mass index above 35 with any of the comorbidities, such as the sleep apnea, diabetes, and high blood pressure. And then Diabetes International actually reduced the BMI to above 30 for patients with insulin-dependent diabetes. There also need to be acceptable operative risks. Like Dr. Buerta was saying, some of them may not actually be fit for surgery, so some of them won't actually be able to have it. A well-informed and motivated patient. So we do like the patients to know a little bit about the surgery before they come in to see us. They also need to be committed to change, and in their first assessment I do tell them that the surgery is just a tool to help them lose weight. If they are obviously not compliant, they can regain the weight. So this is a lifelong commitment. They also need to have family or partner support, and the psychologist I work with, he does do a family visit, and this is just to obviously discuss with the family all the changes they need to make, and also the change in the person, because obviously, you know, there could be self-esteem issues and things like that, so people change afterwards, 2 or 3 years post-op when they're a lot thinner. So any member of the team can voice concern if we don't think that the patient is fit for surgery. So the team will comprise of the physician, the dietitian, psychologist, psychiatrist, and the surgeon. So there have been a few patients who have been booked for surgery, and even at their pre-op visits, if I don't think that they're ready yet, we will actually move the surgery, and we can just work with them just a little bit more. So the surgeries we do is the gastric bypass, and this is done mainly in patients with a body mass index below 50. And just to give you an indication, the pouch size is about 30 mils. So it's about the size of an egg, so it's very, very small. It's predominantly a restrictive operation, but there is a little bit of malabsorption too. And no part of the intestine is removed, so that it can be reversed. There are hormonal changes that will occur, so patients do lose their appetite. And the hospital stay is only 2 nights, so just kind of quite quick and easy, really. Just to answer your question earlier, with the gastric bypass patients, we do generally see about a 30% body weight loss at 12 months, and then we hope that they kind of do maintain that. The next one is the video pancreatic diversion, or the BPD, and this is done with patients with a body mass index above 50. This is both a restrictive and a malabsorptive operation. The sleeve that they make here is about 100 mils, so it's not as small, so their portions will be a little bit bigger, but there's a lot more malabsorption. So if the diet isn't followed, they'll be getting more diarrhea, dumping, smelly stools, things like that. And again, with this operation, we aim for a 50% body weight loss. So yeah, so we're halving a patient. So the role of the dietitian. So when we first see the patients, it would be similar to what we all do in practice. We're obviously taking their weight, their height, and we're working out their body mass index. We always look at their highest weight and their lowest weight too. And if they've been on any kind of past diets before, things like Whaley's, Atkins, things like that, and how much weight they've lost, how long they were able to sustain it. We do, and we have done a little bit of research into this, and on average our patients would have been on diets for about 17 years before they come to us for help. And interestingly enough, a lot of them haven't actually seen a dietitian before, which I always kind of find quite shocking. We also then look at their social history, so where they're eating their food, what are their work conditions like, are they traveling for work, things like that, and their lifestyle, who's doing the shopping and the cooking, are they doing any exercise. We also ask them about the family support, take their family history of diseases, because as we all know, if there is a family history of obesity and diabetes, things like that, it will obviously increase their risk. And then their medical history, if they've got any hypertension, IBS, those type of things. So we actually just deal with them altogether. Then the psychological aspects. Again, we look at, if there has been any kind of binge eating disorder, if they've been using any kind of laxatives, things like that, bulimia or anorexia. And again, with the studies, we've only really found about 7% of our patients with true eating disorders. And I think if I have to think about the general patients, they would be just similar to you and I, maybe with a family history of obesity, working long hours, they can't cook, they can't get, proper food, and, these kind of people really. And then we talk to them about their expectations. So we do talk to them about the amount of weight loss they need to lose pre and post-op. And I think there is also, people think that they're going to go in for the surgery and when they wake up they're going to be skinny, which is obviously not going to happen. So we then obviously discuss the dietary phases. So the first phase would just be a regular small eating plan. Then 2 weeks before the operation, they go on a soft diet for a week and then a liquid diet for a week. And then they have their op, and then they're on clear fluids while they're in the hospital. And then 2 weeks post-op, they're on a liquid diet for 2 weeks, a puree diet for 2 weeks, soft diet for 2 weeks, and then they go back onto their eating plan. So in the first visit, we do a proper full dietary assessment. We make goals for them. We explain to them obviously all the different kind of food groups and things like that. It is also wrong to assume that obese patients are well nourished. So we need to obviously look at if they've got any kind of deficiencies at all. Calcium, potassium, iron, protein, obviously the albumins, and vitamin D is the nutrients at risk. I'm sure you all know already vitamin D is low vitamin D in obese patients. The comorbidities such as the hyperlipidemia, the raised glucose levels, NASH can also be improved obviously with their diet pre-op. And just something there about the diabetes. With our diabetic patients, they do need to take finger pricks and send it to me weekly with the food diary. So we do monitor their sugars. Our main goal, although we do like to see a little bit of weight loss pre-op, our main goal for the diabetic patients is to make sure that they are well controlled. So at the initial visit, we change in their eating behavior. We aim for 5 to 10% body weight loss. So generally, the surgery is booked for 3 months, so we do kind of more see about the 5%. Some patients don't get there, which is absolutely fine, because they do report things like more energy, clothes getting looser, which we all know is very important. And also some of them would have been on a very restrictive diet, so it is difficult, obviously, to lose weight when they do start eating healthily again. They need to have their regular meals, and we need to make sure that they are meeting their protein requirements. Low fat, low sugar, and just while I talk about low fat, low sugar, it's the same guidelines that you all use. So it's lower than 3 grams per 100 grams of fat, and lower than 7 of sugar per 100 grams. We like them to cut out alcohol, whether they do or not, I don't know. But we say no alcohol until the operation and for at least 3 months post-op. And this is again just to get them into good habits. After the operation, they actually lose the enzyme that helps them digest the alcohol, so they become very cheap days. Also, no fizzy drinks, so not even sparkling water, diet drinks, anything like that. Again, after the operation, if they're still in the habit of having fizzy drinks, they're going to be filling up their little pouch with fizz and then not eating. Obviously, we do the reading of the food labels, menu planning, shopping list, and we want them to start acting as if they've had the surgery already. So that would just mean when they're going out to restaurants, ordering things, saying to them, no creamy sauces, things like that too. And obviously then their activity. Just one thing also, I don't like to give out a meal plan. I prefer my patients to be a little bit more in control of their life. And then what they do for me then is to send me their menu plan or food diary, and then I'll change things accordingly. So after working in the UK, I still like to use my Eat Well plate. So I do go through this with them, making sure that they are getting their whole wheat carbohydrates, their fiber-day fruits and vegetables, getting enough protein in, low fat and sugar, and then obviously the dairy products. We do encourage them to use fat-free dairy products right from the word go, because even the low-fat varieties can cause a little bit of nausea and things post-op. So then in the follow-up session, we're checking their blood, seeing how everything is going there, seeing if they've had any kind of weight changes, and just how they're doing on the diet. Some people say it's very easy, some people say it's hard, some people say it's too much food for them to eat. I mean, I'm sure you've heard it all before. We again talk about the exercise and the expectations. With the exercise, even for the very, very heavy patients with knee problems and things like that, we can't expect them to be going to the gym and those type of things, but it's just to start getting their body moving a little bit. And now we've introduced a little test for them, which they all get shocked about. And it is quite an easy test. Well, for us it would be easy, but just asking them what the proteins are, what carbohydrates are, what are they used for, just so that they know, for post-operatively too. Right, then we put them on a soft diet, and this is just to help relax the gut, and it's also to help shrink the liver so it's easier for the operation. The soft diet is just mashable with a fork, so it's no pips and skins and breads. We do need them to be having a good protein intake, at least 60 to 80 grams. So I generally say to them they should still keep all their portions and everything as we have discussed in the first session, and then obviously the low fat, low sugar. They then will go on to a liquid diet, and this is also making sure that they are getting their proteins in. We say that they need to be having at least a cup of food, which is the 250 mils, every 2 to 3 hours. And this is to make sure that they are getting enough protein. And we aim to have at least 2 high protein supplements a day. And then to make sure that they are getting enough fluids in between, which would be their normal water, iced tea, light diet, cordials. They then will go into the hospital for their surgery, and when they come out, they're on a drip, and we also give them syringes of water, which just keeps their mouth comfortable. We don't want them to be taking big gulps of water. With the gastric bypass patients, the next day after the surgery, they'll go for their gastrograph and swallow, and with the BPD patients, it's day 3 post-op that they go for their swallow. When we get the results from this, that's when they start on their clear fluid diet. And this is all provided by the hospital, and it's jellies, consomme, iced tea, light, and water. So when they go home, they start back on the same liquid diet they were on before the operation. So again, very high protein, making sure they're getting their smoothies in, soups with the protein, and then their protein supplements. Because their stomach is really small, obviously the size of an egg, we want them just to be slowly sipping their fluids constantly through the day. And what we aim for is about 100 mils per hour of the food and 70 mils an hour of the fluid. So they are just constantly sipping. Some patients, about 10 to 50% of patients, do become lactose intolerant. So we do need to monitor that, and I always just say to them that they can call me and we can just discuss it over the phone, because we see them 2 weeks post-op. So if this is happening directly post-op, they can just give me a call. Water is also not very well tolerated. A lot of patients say it causes a bit of pain and discomfort, so even just a squirt of lemon or maybe a bit of strawberries and mint just kind of helps take the edge off a little bit there. And then obviously the low fat, low sugar. Then they start on their puree diet, which is for 2 weeks. And this can be a little bit more texture, but everything still needs to be very, very mushy and very, very moist. So even something like fish, although it's soft and you can flake it, the meat itself is very dry. So they'll need to make it a little bit more moist. 50% of their meal needs to be protein. And we just want them to start getting a little bit more into a normal meal pattern, eating every 2 to 3 hours. They mustn't wait any longer than that. If they wait like 4 or 5 hours to eat, it can trigger nausea. So it's very important that they do eat every 2 to 3 hours, especially in the initial phases. And the quantity there is about half a cup of food, which is 125 mils, so it's a really small amount. And they need to be eating this over 30 minutes and practicing their chewing. Then the soft light diet is exactly the same as what they were doing again before the operation. So again, no pips, no skins. Still keeping things quite moist, but at this stage the portion sizes will be increasing then a little bit more, and making sure that they are then at least getting their fluids in. So these phases take about 6 to 8 weeks. So after that, then they can start in their regular eating pattern again. We generally say about 4 meals a day with a bit of an evening snack. And we don't really want them to graze through the day. Some patients we find that some patients, they'll be picking constantly through the day. And when they do this, it just means at their mealtime, they're obviously not going to get their food in. Also, we don't want them to eat and drink at the same time. So basically, if they're always eating, they're not going to be drinking, which will result in constipation and dehydration. We also like them to concentrate on their likes and dislikes, so getting into a more normal way of eating and to lose that kind of diet mentality, which is really tricky. I had a patient just a couple of weeks ago, and 3-year post-op, she's not eating enough food, and she's really scared that her pouch is going to get bigger or break open. So it's really kind of tricky dealing with these type of things sometimes. Always planning the meals, making sure that they are very high quality and they're nutrient dense. Making sure that they're at least having their 50% protein and eating their protein first. Protein needs to be eaten at every single meal and snack. And the fruit mustn't be eaten by itself. Fruit always to be eaten with the protein, because the fruit, the high sugars, can increase the sugar and it can cause a little bit of dumping. So they would have like a fruit and a yogurt or nuts or biltong or something like that. Again, discussing their alcohol consumption with them, and low fat, low sugar to prevent dumping and diarrhea. And the quantity there is about a cup to a cup and a half. So I would say about 3 months post-op, they're still on about a 3/4 cup. So this cup, cup and a half would be more so from about a year onwards. So this is the little picture I give to them afterwards. As you can see, it's the 50% protein at the bottom, The fruit and vegetables will go down to about 4 a day, fruit and veg, and then a little bit of carbohydrates, and then the fats and sugars. Right. There's that bit of a reality check that comes into it, and this kind of happens, I would say, about a year post-op. We do tell them when they first come and see us that the surgery is not a guarantee. It's a tool to help them lose weight. If they're not compliant, they will regain the weight. And we do see in studies and in some of our patients, sometimes you get about a 10 kilogram weight regain, and even with the 5% body weight increase, some of the comorbidities will come back, like the diabetes, heart disease, things like that. So they really do need to be compliant. And it's hard work. So if anybody thinks this is an easy way out, it's definitely not. The first 18 months is generally the most amount of weight loss. So the first year, I always say to them, is free, really. They can't overeat or binge at all. They will get dumping syndrome or diarrhea if they do eat badly. And they always need to be disciplined and compliant with their diets. There's the lifelong supplementation of the vitamin and mineral supplements, and then obviously the annual clinic visits. So sometimes getting patients to come back to their follow-up is quite difficult, as I'm sure you all know already. And it's interesting, the patients who are compliant, those are the ones who come back. The ones who aren't, those are the ones you're always going to have trouble with. Right, so just now to discuss the potential dietary impact post-operatively. I've been talking quite a lot about protein, and there is an element of protein malnutrition if they're not compliant. There's the micronutrient deficiencies, dumping syndrome, nausea, vomiting, and then obviously when women are pregnant. So with the protein, an inadequate protein intake will result in a poor nutritional status, the loss of lean body mass, a reduced metabolic rate, and physiological damage. So an adequate protein intake post-operatively will improve the wound healing, decrease the loss of lean body mass, and improve body composition, enhance weight loss, and increase satiety. But there are going to be barriers. Obviously, the small gastric pouch capacity can result in an intolerance to meat and early satiety. So basically what happens, like I've said, this pouch is about 30 mils. So if you try to fit in, let's say, 100 gram steak, it's going to be very difficult. And they also say that steak and meat, it actually just kind of sits there. The other big thing is textures. So a lot of patients say that they can't tolerate like a steak from the brine because it's really dry, but a rare fillet tends to be a lot better tolerated. There's also the decreased availability of pepsin, renin, and the hydrochloric acid, which can inhibit the protein digestion. And then also the post-operative circumstances. So if the patient does have any nausea, vomiting, constipation, diarrhea, depression, alcohol consumption, and then obviously the lactose intolerance, I said. Right, but now we're dealing with patients. There's also that non-compliance, and as much as I tell them they need to eat 50% protein, a lot of them aren't doing that. The other thing is, there's that feeling of, I'm feeling fine and I am taking my supplements. The reason they feel fine is because they've lost 50 to 100 kilograms, so they're feeling fantastic and they've got energy and things like that. And obviously the supplements, we all know that that's just the micronutrients. So it is kind of discussing with them the importance of the protein, how much they need to get in and things like that, and that they need to do it every single day. It can't just be here and there. We do see them post-operatively at the 2 weeks, 3 months, 6 months for the BPD patients, and then every year after that. And we do need to check their bloods and their albumin status and their protein status. When their albumin is really low, we will then bring them into the hospital and give them TPN. So we give them TPN and we still feeding them, so their gut is still going to be used. Obviously we can't give them a feed because of the small pouch. So with the recommendations, we aim for 60 to 120 grams of protein per day. We need to aim for high biological value proteins such as the lean meats, poultry, fish, eggs, and dairy. And also the protein is going to take priority over the other macronutrients. So when we kind of get to the 2-3 year post-op, I do use the general guidelines of 1 gram of protein per kilogram body weight, but they shouldn't ever go below the 60 gram mark. Right, so just to give you an idea of what 60 grams of protein is. So for breakfast, that would be equivalent of having 2 eggs. For lunch, half a tin of sardines. Mid-afternoon meal, 200 ml of fat-free yogurt. For dinner, 100 grams of chicken, which is about a palm size of chicken. And then an evening snack, or through the day, would be a glass of milk. So it's actually quite a lot of food that they need to get into their 30 ml pouch. The other thing is the lactose intolerance. So this can happen in about 15% of patients, 10 to 15%, and it would generally happen from like directly post-op and maybe until about 6 months, and then they tend to kind of deal with it a little bit better. Now with the products that are available to us, they do tolerate the lactose-free milk. And then the normal fat-free yogurt and fat-free cottage cheese tend to be okay, but you do obviously get the lactose-free yogurt now too. And if they really want to, they can use a lactase enzyme to help with the digestion. But like I said, with these new products on the market, we don't tend to use the enzyme that much at all. With regard to the protein supplements, we only use these really in patients who fail to meet the protein requirements through diet. The good thing about them is that they can increase the protein without increasing the fats and the carbohydrates, and we do discuss this with the dietitian. So we'll kind of discuss these with the patients. As you can see the picture, there's the Future Life High Protein. What I really love about this product is that they can get it anywhere, and it's very cost effective, and it's lactose free, so they can obviously then put their lactose free milk in it. There's a lot of products on the market, very good products on the market. The problem is some of them are too high in sugar, and then they cause dumping and nausea post-op. So this one is very well tolerated. They can't use the Future Life high protein bars though, because it's too much sugar. So they're kind of stuck with this. Right, so just the tips that we give to the patients. They always need to eat their protein first. 50% of their meals will need to be protein. And they can increase their protein by food fortification. And this is by adding the biltong, almonds, cottage cheese, yogurt, peanut butter to foods. So basically, if they can't, let's say, fit in a palm size of chicken, they can mix it maybe with a bit of nuts, like in a stir fry or something like that, then to be pushing up the proteins there. And then high protein smoothies and protein supplements can then also be used. Right, so in terms of the micronutrients, the doctors generally deal with this. Obviously, we get their blood, so we do have a look at it. But the doctors will prescribe more of the vitamins and minerals if they need it. The main one we always look at is the albumin. So in the BPD patients, their albumin can be low for the first kind of 6 months, and this is just while the sleeve dilates. They will then need to use the meal replacements, and we'll be aiming for a minimum of 90 grams of protein per day. And some of the patients then would need TPM to push this up. In the gastric bypass patients, it's generally post-op, and we would be aiming then for a minimum of the 80 grams of protein. Vitamin D, a lot of them are supplemented pre-op with vitamin D anyway, so they'll just continue with that. The vitamin B12, they will be getting an injection every 3 to 4 months. And then, as kind of required. With the calcium, some of the calcium supplements aren't very well tolerated and they're not absorbed. So we give them a specific one, and then obviously just like what you would do, you shouldn't really take the calcium with the iron too. The iron supplement, again, some people opt to go for an iron infusion because the iron supplement can cause constipation. So some of them would opt in for the infusion, but again, it's the minimum required dose. The vitamin A and fat-soluble vitamins in the BPD patients, they'll go for a vitalipid infusion at 3 months. And then when we see them at 6 months, 12 months, and we look at their bloods, we'll just see if they would need it or not. The other ones, zinc, thiamine, and the folic acid, these are just kind of looked at, and if they need them, we will give them to them. But they are given a multivitamin and mineral every single day that they would also need to take. Right, a little bit about dumping syndrome too. I'm sure you know a little bit about dumping syndrome. And basically what happens, this generally would happen within the first 15 to 30 minutes of eating food. And what will happen is that the food will get dumped from the pouch quickly into the intestine. So your body almost wants to dilute it, which will push obviously a lot of fluids into the gut, which can cause diarrhea. Also, the sugar levels go high, so a lot of insulin is released, so therefore your sugar levels will drop. So this will then cause things like dizziness, sweatiness, fatigue. And some of the patients say that they need to just lie down for about 20 minutes afterwards. Diarrhea obviously can also happen, and I would say diarrhea happens mainly from the fats, whereas the dumping with the heart palpitations and things like that generally happens from the sugars. And also in the gastric bypass patients, they're more affected by the sugars than the BPD patients. The BPD patients are more affected by the fats, and they'll get more diarrhea and smelly stools from the fat. So in terms of managing dumping syndrome, they need to eat slowly and chew their food properly. And like I said before, we aim for them to be eating or taking at least 30 minutes to be eating their food. They need to sit upright. They need to eat their protein first, and they mustn't eat and drink at the same time. So we're aiming for them to not to be drinking 20 to 30 minutes before or after they operate, after their meal. They need to avoid high calorie or carbonated drinks and avoid, obviously, the sugars and refined carbohydrates. The next thing is the nausea and vomiting. Nausea and vomiting, I would generally say, occurs in the first sort of 3 months, and this is why they're changing their progression and things like that. We always look at if the patient is eating too quickly. And this is something that can happen quite a long time afterwards. Again, I had a patient a few weeks ago, she's 3 years post-op, and she couldn't understand that because she hadn't changed anything in her diet, but now she's getting nauseous. And we worked out that she was eating her meals now in 5 minutes. So it is going to still kind of happen in the future. Did the patient then eat and drink at the same time? Did they eat too much food? And again, this happens, I would also say, mainly in the men, post-op, because they're so used to having big portions. And I think we all know, we're all the same, you'll just have that last little spoonful, and you think, I'll just quickly fit this in. And they still do the same, and then it's too much. So it's always just to kind of watch for the portion size. And then also then to eat non-tolerated food. And obviously then if they didn't eat or chew well enough. And this would especially be then with meat products. And then lastly, just a little bit about pregnancy. Bariatric surgery should not be considered for treatment for infertility. But what does happen, patients who have had subfertility with or without PCOS before bariatric surgery are more likely to conceive post-operatively. So we do generally say to the females that they shouldn't be falling pregnant within the first year, because this is obviously when they are getting their most weight loss, and we don't want any damage to them or to the fetus. With the pregnancy, we do ask the patients to come in as soon as they know that they are pregnant. And then we see them then at 7 months, and then at 3 months after the baby is born. We're looking at their micronutrients, and what we generally say is that they need to take all their vitamins and minerals as prescribed, because that's it'll still be suitable. The albumin and protein intake, this is always quite a problem. So basically their albumins will fall because of the fetus and the growth of the fetus. So if they're not getting in enough protein, the fetus isn't going to grow as well as it should. So sometimes, I mean, I've had patients on about 100 to 120 grams of protein, which is quite a lot. We do need to take into consideration the nausea and the vomiting. And also, you know, like in normal practice, you may say have ginger biscuits and things like that to help. And obviously with the high sugar and fat content, our patients can't have things like that. And then we use, you know, the normal national guidelines. With regard to the weight gain, it's exactly the same as normal for patients, your patients. But generally speaking, the patients would be at a healthy weight by the time they do fall pregnant. So we would just be aiming for the normal kind of 10 to 11 kilograms of weight gain. And some of the patients who are a little bit overweight still, we generally find that they would only gain maybe 2 or 3 kilograms. And that's it.